This is our presentation on post-polio syndrome with our patient Marvin Hewitt. His general medical history, his name is Marvin Hewitt. He's a 64-year-old male. He was diagnosed with post-polio syndrome last year, and he was diagnosed with polio at the age of 8 years old. Social history, he lives at home with his wife and 24-year-old daughter. His wife is 58 years old and retired. He has a 27-year-old son, and his wife live 2 blocks away. They have 2 children, ages 3 and 5 years old. He visits his grandchildren 4 to 5 times per week. He works as a high school history teacher and plans to retire next year. He also volunteers at church as an English and second language tutor and a fundraiser. And his leisure activities include going to the movies, visiting museums, and dining out. His current and prior level of function. Function prior to the post-polio syndrome onset. He was independent in all his ADLs, mobility, yard work, and major home repairs. His function currently following the post-polio syndrome onset. He's still independent in all his ADLs, but due to rapid onset of muscle fatigue and weakness, affecting his lower extremity greater than his upper extremity, he has had to hire help for major repairs and heavier yard work.
His acute care episode 2 weeks ago, he became ill, which he originally thought was a cold, but then 4 days ago he was admitted to the hospital and diagnosed with pneumonia. He received IV antibiotics and respiratory therapy, and then he was referred to a skilled nursing facility. And then at the skilled nursing facility is where we see him for his initial evaluation. So he was referred for subacute rehab after his hospitalization, secondary to tremendous decline in function, resulting in an inability to return home. Significant past medical history was the polio at age 8, which now he uses an AFO on his left lower extremity and a cane for ambulation. He has hypertension. He had pneumonia 2 years ago as well. He has a cataract in his left eye, and he had a hernia repair 20 years ago. His medications include Tylenol just for his muscle stiffness and pain, Tenormin, which is for his hypertension, and then a multivitamin. The side effects for his hypertension medication include a slow and uneven heartbeat, feeling of lightheadedness or fainting, shortness of breath, even with mild exertion, swelling at the ankles, feet, nausea, stomach pain, loss of appetite, a low fever, dark urine, clay-colored stool, jaundice, depression. Some of those side effects could also be symptoms that he's experiencing from his decline in function. So you just have to watch out to make sure you can tell what the difference between his medication is and what his deconditioning is. Cognition, he's alert and oriented ×3, an intact memory and intellect. He doesn't demonstrate any perceptual deficits on a gross examination. His sensation is intact. His range of motion is within normal limits for all of his extremities, neck, and trunk passively, with an exception of bilateral plantar flexion contractures, measuring -5 degrees of dorsiflexion on the left and -10 degrees of dorsiflexion on the right. His strength, his upper extremities are within normal limits, and his lower extremities are between fair to poor, the proximal being weaker than the distal, and his trunk measures poor plus to fair throughout. Balance, his sitting balance is normal, his standing balance is moderately impaired, and he requires a walker in min assist at this point in time to ambulate. He can only tolerate minimal changes to balance with his rolling walker. Pain, no more than just cramping and stiffness in his lower extremities. Edema and skin integrity. His skin is intact throughout, but he has moderate bilateral distal lower extremity edema, for which he wears TED hose. Mobility. Bed mobility, he can roll independently from side to side. Bridging, he requires a min assist, soup to sit, min assist, and he has no equipment in his bed. Transfers, he requires min assist for sit to stand, bed to wheelchair, wheelchair to commode, or toilet to wheelchair, and then a tub or a shower transfer and a car transfer have not been attempted. Gait, he's able to ambulate 100 feet with a rolling walker with min assist using his left AFO. However, right now his AFO is poorly fitting because of his new plantar flexure contracture. He has frequent posterior losses of balance and occasional knee buckling on the right. Functional mobility, the patient is independent in wheelchair setup, propulsion, and maneuvering on a level surface, and he is able to complete basic functional tasks. He requires min to moderate assistance when ambulating with a rolling walker and demonstrates poor endurance by fatiguing quickly, and this renders ambulation non-functional. Self-care, he's independent in most aspects of his self-care, from a seated position, including feeding, grooming, upper body dressing, and lower body dressing, excluding standing to hike and don his underwear, that he requires minimal assist or moderate assistance to do. And home management, he's dependent in all home management tasks at this time. That's the chart for his manual muscle tests. I won't go through all of it. The ICF model, his health conditions was this acute episode of pneumonia and post-polio syndrome, body structure and function, which we just went through, but to briefly summarize, is the plantar flexion contractures, his strength, deficits in his lower extremities and trunk, his standing balance, and distal extremity edema, and some muscle stiffness pain. His activities, what he's able to do is he's able to ambulate with a rolling walker with min assist for 100 feet. He's able to feed himself, groom himself, do some upper body dressing, and he's able to roll in bed. His limitations include some of the lower body dressing, bathing and showering, supine to sit, sit to stand, transfers, and he's unable to drive at this time. So that means that his restrictions on participation include working, volunteering at church, and playing with his grandchildren, which he likes to do on a regular basis. However, at this point in time, he's still able to sit and socialize with his visitors and able to participate in social activities that are put on through the extended care facility. His environmental factors for his internal environment, the positive is that he has a really good support system and is amenable to therapy. Negative is that a lot of the activities that he finds pleasurable are mostly sedentary, which puts him at risk again for acquiring pneumonia and not increasing his functional capacities. So external environment positive is that his work environment can be done with modifications. So because he has a limited endurance, he might have to make some of those modifications, but it still can be done. Negative is that this delay in returning to work may put financial burdens on his family and resulting in an inability to spend the money to modify his home and other financial issues.
Patient goals. The patient will be able to independently be able to complete a car transfer with his walker to be able to drive. The patient is to demonstrate all transfers independent with AFO and straight cane without loss of balance or reports of fatigue in order to improve functional mobility, quality of life, and return home. The patient is to demonstrate independent lower body dressing with or without garment aids, without loss of balance, shortness of breath, or reports of fatigue to improve independence and ability to perform ADLs. The patient will show improved balance by demonstrating tolerance to moderate perturbations to balance from all directions without loss of balance, without an assisted device, on a level surface in order to improve independence in toileting and showering. The patient will demonstrate independent ambulation with AFO and straight cane for greater than or equal to 300 feet on a level surface to facilitate the patient's return home and to work activities. The patient will be able to stand and ambulate on level surface using a straight cane for greater than or equal to 15 minutes without loss of balance, shortness of breath, or reports of fatigue in order to return to work as a teacher. The patient will demonstrate greater than or equal to 3+ out of 5 strength on the right plantar flexors, greater than or equal to 3 out of 5 strength on the right hip flexors and adductors in order to facilitate return to safe driving. The patient will independently ambulate 200 feet with AFO and walker on a flat surface without loss of balance to be able to return home. And lastly, the patient will be able to demonstrate secretion clearance techniques appropriate to effectively participate in treatment and decrease the risk of reacquiring pneumonia. The plan of care. The plan of care is going to focus on education on energy conservation / self-management and airway clearance techniques, and also dyspnea recovery positions. It's also going to work on transfer training, increase the ankle range of motion to help with the contracture, strengthen the trunk and lower extremities, increase standing balance, and gait training. Progression. The progression is generally slow with somebody with post-polio syndrome, and generally a rotation of exercises such as stretching, aerobic conditioning, strengthening, endurance, and range of motion is used. The program should begin at 20% of the maximal capacity, and that is maintained for a month before increasing by 10% every month until the maximal exercise capacity is reached. And start with increased rest periods to give them more breaks and slowly decrease as the patient progresses.
Some strategies to help achieve these goals. The patient could keep an activity journal to make sure that they log everything that they're doing. They could attempt multiple learning styles to see what works best for the patient, build up the patient slowly, and educate them thoroughly as to what you're doing. Teach them dyspnea recovery positions and deep breathing exercises to assist in all aspects of care. The rehabilitation potential of this patient is good. The comorbidities, they have post-polio syndrome and hypertension. They have good family and social support, and the patient should progress to a prior level of function prior to the acute care episode without significant complications, but it will occur at a slower pace due to the nature of post-polio syndrome. Some age-related changes that affect patients with post-polio syndrome, when you're looking at the musculoskeletal system, they usually have reduced cross-sectional area and fiber size and number. They have increased collagen and aggregation in periarticular structures, which leads to increased stiffness and risk of tendon rupture. When you're looking at the nervous system, they have reduced alpha motor neurons, reduced acetylcholine and deformed neuromuscular junctions, increased sway, reduction to reaction times, gait speed, anticipatory reactions, and tolerance to sensory conflict, explicit and declarative memory loss. Cardiopulmonary system, they have decreased max heart rate, exercise stroke volume, ventilation perfusion ratio, and they have increased afterload, blood pressure, stiffness in heart and chest wall, and overall a less productive cardiopulmonary system. Some of these changes, however, are responsive to training, so that's something to keep in mind when working with this population.
Okay, a study done called Randomized Controlled Trial of Strength Training in Post-Polio Patients. This study had 3 hypotheses. The first being that after moderate intensity strength training, post-polio patients would show strength improvement comparable to that in healthy elderly subjects. 2, that such training does not have a detrimental effect on the motor unit survival, and that part of the strength improvement is due to an increase in voluntary motor drive. subjects. The subjects were recruited from a university post-polio clinic and a local post-polio society or support society. A total of 31 subjects were interviewed, but only 10 of them met the inclusion criteria. They were randomly distributed into training and control groups, and then 9 healthy subjects were recruited for the training control group. The inclusion criteria for the post-polio subjects was that there was a history of prior poliomyelitis in an otherwise healthy subject, and one or both upper extremities had to be affected by the polio, and they had moderate motor neuronal loss in the median nerve innervation of the thenar muscles with a motor unit number estimate, or MUN, between 10 and 90. The methods used for the study, the pretesting, all of the subjects underwent max voluntary contraction, voluntary activation index, tetanic tension, and the MUN of the thenar muscles were measured and calculated. And then the training, they underwent the strength training 3 times a week for 12 weeks, and they had 3 sets of 8 voluntary contractions held for between 3 and 5 seconds. The initial training was at 50% of the max voluntary contraction and increased by 10% once the subjects consistently met that load. And then every 4 weeks in the 12 weeks, all of the subjects underwent testing again for the max voluntary contraction, their tension, or their twitch tension, tetanic tension, MUN, all of them were remeasured, and then they reset the MVC levels for their training. The statistical analysis, a one-way ANOVA was used to determine the differences in the physical attributes and baseline physiological function between the exercise and control group. Training-related changes and the physiological functions in each subjects were analyzed using paired t-tests, and independent t-tests were used to analyze differences between the training and control groups. The results of the study found that the mean max voluntary contraction of those in the post-polio subjects and in the training groups increased significantly more than the control group. Also, that the training group showed a significant increase in VAI and a non-significant increase in tetanic tension. The training group had a relatively unchanged MUN and motor unit amplitude and distribution, and also that the healthy elderly that underwent training showed a significantly increased max voluntary contraction. However, their increase was slightly less than the increase shown in the post-polio patients, meaning that the post-polio patients increased at a greater rate than the actual healthy elderly group. The strengths of the study include that the authors used a really detailed explanation to validate their measurement protocols for the MVC, VAI, tetanic tension, and MUN. Then they also used a detailed explanation to say why they selected these techniques to begin with, because a lot of techniques used to measure muscle changes are invasive and then would actually cause harm to the patient. And then they showed really good significant differences in their data, but then on top of the significances that they showed, they also showed really good trending data towards the direction that supported all 3 of their hypotheses. Weaknesses include the sample size was really, really small. There was only 10 subjects for post-polio patients and only 9 for the healthy adults or elderly. And the inclusion criteria was way too strict, meaning that you're not able to generalize it into the entire post-polio population, because the subjects were only allowed to have post-polio syndrome and not allowed to have any other comorbidity, which is a very, very small section of the entire post-polio population. And The mune of the healthy subjects weren't taken, and the post-polio subjects' munes were then compared to published norms, which wasn't consistent for any of the other things or measurements that they took, which you can't do because their healthy adults group was only 9 people large, which does not make it equal to that of published norms. And there was a short period for the treatment protocol, and they only used one minor muscle group of the upper extremity. The clinical relevance is that it gave us an appropriate protocol for patients with post-polio syndrome, and that it showed that strength training or submax strength training doesn't actually destroy the motor neurons. Future studies is that they could have studies that are basically the same as this, just with a larger subject pools, longer training periods, and more varied muscle groups.
Alright, the article that I looked at was titled Perceived Disability, Fatigue, Pain, and Measured Isometric Muscle Strength in Patients with Post-Polio Syndrome. In the article, they did standardized testing to measure the disability and fatigue and pain, and used manual muscle testing to measure isometric muscle strength, and they compared the results of what they got. The findings show that there was a correlation between patient-reported fatigue, pain, and muscle strength with a decrease in the ability to perform activities of daily living. There was a disassociation found between the patient's subjective complaints and their measured leg strength and oxygen uptake. There was a significant association found between the measured isometric muscle strength and the patient's subjective measure of their own leg strength, although there was not a correlation between the measured muscle strength and perceived muscle pain. Patients with post-polio syndrome use a lot of energy to get through their day. The design, it was a prospective cross-sectional study. External validity, there was 32 participants, 8 of which had a diagnosis of post-polio syndrome and 24 had post-polio syndrome symptoms. All were mobile enough to walk independently or with an assisted device. Internal validity, standardized tests were used, so it has high internal validity. The fatigue severity scale, disability rating index, and pain visual analog scale were all used. Limitations. The study only looked at patients with post-polio syndrome that were able to ambulate. They didn't look at any that had it severe enough to where they were confined to a wheelchair. It also had a small sample size, and there was some poor internal validity in that muscle grade scores were averaged together and individual muscles weren't looked at. So with post-polio syndrome, different muscle motor units can be affected, so you need to be as specific as possible. And also they used an inappropriate cycle ergometry protocol because all the patients had leg weakness or leg pain, so they probably should have used a protocol that didn't incorporate legs, so maybe arm ergometry. Clinical relevance. Physical therapists should look at the relationship between the results of an objective test and the subjective information that the patient provides to plan the treatment intervention. So for instance, if the objective tests show that the patient has strong muscles but subjective, the patient doesn't think they're strong, or the patient thinks they have high pain, maybe use more coping techniques and psychological stuff rather than physically strengthening the muscles. And in manual muscle testing patients with post-polio, make sure that you isolate the individual muscles that you want to test. And some potential for future research, maybe investigating a larger sample size and fix the physical fitness test so it's more appropriate for the population.
The article I looked at was Walking in Post-Polio Myelitis Syndrome, the relationships between time-scored tests, walking in daily life, and perceived mobility problems. So some of the questions the study aimed to answer were, 1, does walking at a preferred speed in a clinical setting reflect the level of effort and characteristics of normal walking in the actual circumstances of daily life? 2, does the performance in walking test relate to the amount of walking in daily life? And 3, does a relationship between perceived physical mobility problems and the amount of walking in daily life exist? The findings, the patients with PPS do not adapt their behavior to their perceived mobility, and what PPS patients self-prefer to walk at is lower than what they actually do in daily life. And their daily living exerts more energy than standardized conditions. So basically, when they did these walk tests, they did 2 of them. They had do a self-preferred test, and then they also did a time test to see exactly how far they were going during that time when they were walking at a max pace. And then they compared that to what they measured via EMG while they were at home. And what they came to find is that when they were given their self-preferred walk time to walk around the track, they were actually walking at a lower pace than what they actually do in daily life. So in this design, they had, it was a within subjects design. External validity, all of the subjects met the criteria necessary to complete the research, and none were excluded. So what they wanted is these patients had to have one leg that was actually worse than the other when it came to PPS, so it was weaker. And that was pretty much it. They just wanted that to be throughout the population that they selected from, and they were allowed to use assistive devices if they wanted to. The sample was 24, and it was 20 females and 4 males, so that was not very indicative of the PPS population. When looking at internal validity, the tools used to measure and collect the data were common, and they're pretty easy to use. So they used heart rate monitors, EMGs, where they put electrodes and hooking up of an activity monitor that was used while they were in their home. And then they did a Nottingham health profile, which is a questionnaire, kind of looking at their perceived mobility. Some of the limitations: the participants in the study were all individuals with very different lives. They had general levels of activity in day-to-day living. All the participants suffered from post-poliomyelitis and syndrome, and their activity levels might not have been very comparable to one another, and that puts into question what general actually means, because how do you actually quantify what is general? The clinical relevance of the study: clinicians can look at the study and see that those with PPS seem to have a perceptual deficit when it comes to their abilities. They think that they can do less than they actually do. They report difficulties, but they don't change their ways of life to actually adapt to these difficulties that they're actually saying that they have difficulties with. And by understanding that these subjects have that skewed perception of how much they are doing, clinicians can utilize the information to harness and tailor a program that will meet their deficits safely and also actually target the psychological issues that they're having. Potential future research. The future research could span to different aspects of daily life other than just walking, and research could use various perceptual scales that compare the psychological changes that occur while doing these various tasks. Overall, state of evidence on the topic of the article, when we're looking at that, research on functioning of PPS patients, but the perceived perception in activities is generalized and scarce when it comes to the evidence.
The study that I looked at was titled Short-Term Effects of Aerobic Exercise on Functional Capacity, Fatigue, and Quality of Life in Patients with Post-Polio Syndrome. The design of it was a prospective randomized control trial, and it looked at determining whether or not exercise had an influence on aerobic capacity, fatigue, and quality of life. The exercise, they were broken up into 2 groups: a home exercise program versus a hospital program. Aerobic capacity was tested by using their VO2 max. The fatigue was tested by the fatigue severity scale and the fatigue impact scale. and the quality of life was tested by the Nottingham Health Profile. There were 28 subjects that completed the study. The subjects were put into two groups, a hospital-based one which had 15 subjects and a home-based group that had 13 subjects, and one of the limitations was that it was a very small sample size. Some of the other limitations in the study, further studies with stricter control on the home exercise group are required to establish the reflection of this improvement in objective data. It's a relatively short rehabilitation period. It was only an 8-week study, and there was no long-term follow-up of the subject after the study was completed, and there's also no control group for comparison. Strengths for it, it's the first known study to compare hospital-based exercise programs versus home-based exercise programs, and it assessed aerobic capacity, quality of life, and fatigue in regard to exercise effects on post-polio syndrome patients. The results of the study, there were significant improvements observed in both groups. However, more improvement was observed in the hospital-based group compared to the home-based exercise group in VO2 max, fatigue severity scale, the fatigue impact scale, and the Nottingham Health Profiles. Patients will benefit from an exercise program that includes aerobic training using a treadmill, whether the program is administered in a structured setting as a hospital or in the home of the patient. These patients will have increases in VO2 max, quality of life, and decreased fatigue levels.
So some clinical pearls then, or take-home points. The patients with PPS, they use a lot of energy to get through their day, so that's going to affect the treatment that you're going to provide. When you're testing a patient with PPS, you want to test the isolated muscles manually. Not all of the muscles are affected for this reason, or not all of them are weak, so you want to make sure that you're looking at the ones that you need to target for your treatment. You also want to make sure protocols are appropriate for the PPS patients before utilizing them. Many patients with PPS will report difficulties, but they'll have a hard time adapting their daily lives to make the necessary changes to accommodate for those difficulties. So that's something that you want to keep in mind. They're used to being able to do whatever they want to do, and they're going to do it regardless. So you really want to try and target your treatment to make sure that they're trying to adapt stuff at home. PPS patients, they don't always perceive their deficits accurately, so you should monitor their progress and potential for overuse and further damage of the motor units. And you also want to make sure that you're treating their psychological issues as well, whether that's coping mechanism or something along those lines. PPS patients will also benefit from aerobic exercise training programs, and that can be in a setting of work or at home, and treadmills work really well for this as well. And yeah, that was pretty much our presentation, and thank you for listening to it, and we hope you guys enjoyed it.